All right, can you all see my screen?
Very well, sir.
All right, sir. So we can fire on. Thank you.
I should read, right? I go ahead.
Yes, please. I'm just supporting you here.
Okay. Which of the following statements about digitalis induced arrhythmias is correct? Atrial tachycardia with block is diagnostic of digitalis toxicity. Non-paroxysmal junctional tachycardia is highly suggestive of digitalis toxicity. The development of atrioventricular dissociation is in a patient taking digitalis is a sign of digitalis therapy, but not an indication of digitalis toxicity. Frequent ventricular premature beats are rarely a sign of digitalis toxicity. Okay, if I can make some trials here, D is out of it. Frequent ventricular premature beats are rarely a sign of this. C is out of it. The development of AV dissociation in a patient taking digitalis is a sign of digitalis therapy, but not indication of digitalis toxicity. C is out of it. So this concern is between A and B. B says non-paroxysmal junctional tachycardia is highly suggestive of digitalis toxicity. A says atrial tachycardia with block is diagnostic. As a matter of fact, digitalis toxicity, the much I could remember, digitalis toxicity in ECG, there is, I don't think there is any diagnostic, what do you call it? Diagnostic feature, exact diagnostic feature that is exclusive to digitalis toxicity. It is actually a suggestive feature that we have, which is usually diffuse in almost all the leads. So I think I would rather go with B. I don't know what the answer says.
Let me just add an additional comment to that. Actually, for digitalis toxicity, we can have digitalis toxicity or excess. For toxicity, they've talked about bidirectional, I think that's ventricular tachycardia, to be highly suggestive, but not pathognomonic. Because they also see it in, I think that's CVT2. So, but if you see bidirectional ventricular tachycardia, it is only suggestive of digitalis toxicity. Then most times, atrial tachycardia with block is not diagnostic. It's just telling you that there is an excess of digitalis in the blood, but it's not diagnostic. So most times for digitalis toxicity, we say junctional tachycardia, and that by ventricular directional tachycardia, which is also seen in, I think that is catecholamine. I can't remember the full name now, but I think that those are the two common ones that have it. Those are just the things that I want to add. I don't know whether anybody has any other comments. Thank you.
Thank you very much. I think I just checked the answer now. The answer happened to be B. In absence of further comments, I think I'll move on. Question number 72. And a 2-year-old man presents after a recent non-ST elevation myocardial infarction. Coronary angiography revealed severe transversal disease with 100% occlusion of the proximal left anterior descending coronary artery, 100% mid-right coronary artery occlusion, and 70% stenosis of the proximal left circumflex coronary artery. Echocardiography demonstrates akinesis of the entire anterior wall, septum, oh, wow, and mid-apical anterolateral wall with an estimated left ventricular ejection fraction of 20%. Wow. Myocardial viability was evaluated using cardiac positron emission tomography (PET) with rest iridium 82 flow tracer and fluorodeoxyglucose 18 metabolism tracer, as shown in figure 1.17. Which of the following statements is true? We look at the picture. A, the images show a large portion of PET perfusion metabolism mismatch in the LAD distribution. B, this finding is consistent with presence of scarred non-viable myocardium. C, radionuclide techniques are less sensitive than measurement of ionotropic contractile reserve by dobutamine echocardiography for detection of viable myocardium. Survival benefit associated with revascularization of hibernating myocardium has been demonstrated in randomized clinical trials. If I should just make a comment here before we start answering, I think, let me see if there is option E. Okay, there's no option E. Survival benefits associated with revascularization of hibernating myocardium has been demonstrated in a randomized clinical trial. I think this is true. Before we start going for the imaging analysis, and they say which of the following statements are true, or rather is true. Number one, the images show a region of PET perfusion metabolism mismatch in the mid left anterior descending distribution. Left lateral anterior.
Okay, sorry. If I'm not really too conversant with this PET images, but if I can just guess, I don't know if I'm correct. Am I audible?
You are very audible, sir.
Okay, at the first row up there, I think it's the perfusion study with rubidium, while the metabolic tracer images are the ones, the second row following it consecutively. So first one shows us perfusion, while the next one following is what is showing us about the metabolic activity of the myocardium. I don't know if I get that correctly.
That's what it looks like. All of us are, a great number of us are not quite conversant with it really, but that's what it looks like really. Because that's the labeling. The second one said FDG metabolism. That's the second row.
So in that case, if we look through the images, we'll see that, for instance, here, there is actually some perfusion defects that we can see here as the apical segments. It is not replicated in the metabolic, when we are looking at the images using the metabolic tracers. Okay. Likewise, if we go down to these other last two rows, the defects still persist. It's almost the lateral apex, but it is not persisting when we are using the metabolic tracer. So based on this, I think we want to agree that there is a perfusion metabolism mismatch in these images. My opinion. Thank you.
In LAD, they said they were particular about it. In the mid LAD distribution, Okay. In absence of further contributions or clarification, can we read the explanation and the answer, please? If the House permits, I'll go ahead to read it.
Please go ahead.
Thank you, sir. That's question number 72. The answer they said is A. Thank you very much. And among nuclear imaging techniques, flow and metabolism can be simultaneously assessed with PETs using radium-82 or nitrogen-13 labeled ammonia as flow tracer, and fluorodeoxyglucose as a metabolic activity, as a metabolic tracer. A mismatch pattern, that is preserved metabolic activity despite reduced flow, as in this case is the mid-left anterior descending artery distribution, is indicative of hibernating viable myocardium. Conversely, a true myocardial scar would demonstrate a reduced flow and a matched reduction in metabolism. Additional modalities used to assess for viability include dobutamine echocardiography, which is more specific for but less sensitive than radionuclide techniques, and delayed hyper-enhancements as assessed by gadolinium-enhanced magnetic resonance imaging, which has resolution and can accurately estimate the transmural extent of myocardial scar. Observational studies have suggested that patients with ischemic cardiomyopathy and large areas of viable myocardium induced identified by non-invasive cardiac imaging have superior rates of survival, more substantial improvements in left ventricular function, a greater reduction in symptoms of heart failure, and a better exercise tolerance and revascularization. However, the prospective and randomized STITCH trial failed to show a difference in the outcome with revascularization in the patients with or without viable myocardium. Thank you, Chief Sewa, for that your input.
Thank you, sir.
Okay.
Hello.
Can I go? Okay, yes, sir.
Yes, please. Thank you so very much. I just wanted to remind us a bit. I remember Professor Ladimeji explaining this thing once.
The other day.
Yes, he had explained before that if you look at, I don't know, the picture, can we see it a bit better? If you, as the first speaker said, if you look at the, okay, yes, the middle, how do I, yeah, 1, 2, 3. If you look at the third horizontal row, third one.
Yes, sir.
You see that the first one is the rubidium, then the second is the fluorodeoxyglucose tracer. Now, you see that the rubidium, as was rightly said, shows some perfusion defects. If you look at the last 2 frames, yes, you can see that there are defects. But look at the FDG that tells us about metabolism. That's the one below exactly. You see that the FDC shows that there is viable tissue there.
Yes.
The one above shows perfusion defect, but the one below, which is the FDG, shows that there is metabolism ongoing there, which means there is viable myocardium. So, cells there are scarred or necrotic would be wrong, because if that were the case, then you wouldn't have the uptake of the FDG tracer. Exactly. So it's important to just know that that was what I wanted to point out. Thank you so much.
Thanks very much. That's a lot of illumination, really. The next question, please. Or is anybody making further contributions? Question number 73. Which of the following statements regarding physical findings that distinguish the murmur of aortic stenosis from the murmur of hypertrophic cardiomyopathy is true? The strain phase of Valsalva maneuver decreases the intensity of murmur of both AS, of aortic stenosis and hypertrophic cardiomyopathy. The carotid upstroke of hypertrophic in hypertrophic is brisker than in aortic stenosis. The murmur of aortic stenosis and hypertrophic cardiomyopathy both radiate to the carotid areas. If a systolic trail is present, it is most often located in the second right intercostal space in the hypertrophic cardiomyopathy and at the apex in the aortic stenosis. Squatting increases the intensity of murmur of hypertrophic cardiomyopathy. Opinions, please.
Okay.
Well, we know that for the murmur of Hokum, if one demonstrates Valsalva, there would be a reduction in venous return to the heart. And with that reduction, then the distance between the septum and the anterior mitral valve leaflet would be shortened, and that would translate to an increase in the intensity of the murmur, I think, if I remember correctly. So to say that both of them, because I know that AS and Hokum, they are usually opposites of each other. So Valsalva cannot do the same for both. So I know that option A is false. I'm not certain about option B, but for the option E is also false because of what I've just explained. Squatting will reduce the intensity of the murmur because it increases the what am I saying? It increases now. Squatting increases a resistance in such a way that the distance between the septum and the anterior mitral valve leaflets are wider, and so the murmur will be less. So squatting does not increase the murmur of Hokum. Squatting will decrease the murmur. So those two options are what I can comment right about. Then, if a systolic thrill is present, it is most often located in the second right intercostal space in Hokum and at the apex in AS. No, if a systolic thrill is present, I can't remember. I have to. Okay, please comment. So.
Okay, Dr. Jai, can I help you?
Okay, Dr. Alagui.
Okay. As he said rightly, A is false because Valsalva increases Hokum and then decreases AS. Then E is also false because squatting increases preload, thereby squatting increases preload. So in AS is going to increase the murmur, in Hokum is going to decrease it, so it's out. Then now, let's go to D. If a systolic trill, AS murmur is heard in the right second intercostal space. So if you feel a systolic trill there, that means it's AS. Then if you feel a systolic trill in the apex or the left fourth intercostal space, is Hokum. So they interchanged it here. That made D false. Then C, murmurs of AS is radiated to the neck and the carotid, but murmur of Hokum is not radiated to the neck and carotid. So this makes it B is the correct answer. In AS, the obstruction is fixed. So from the beginning to the end of systole, the uprising, the carotid upstroke is almost the same. That's the Pavus, what do we call it? But in Hokum, with systole, the carotid upstroke will be faster first. Then as the LVOT narrows, it decreases. So that's why B is correct. Thank you.
Thank you very much. And that is actually really correct, going by what the textbook says. Any more contribution, please?
I think you should proceed. Her explanation was quite very good.
Thank you very much. Question number 74. Which of the following statement is correct regarding the oral anticoagulants dabigatran, rivaroxaban, and apixaban in the treatment of patients with atrial fibrillation, AF? 1. These agents are effective as warfarin for prevention of thromboemboli in patients with AF and mechanical heart valves. Each of these drugs can be used safely in patients with advanced renal disease. IV indarusizumab rapidly reverses the anticoagulant of dabigatran. For patients whose international normalized ratio level on warfarin have varied due to non-compliance, rivaroxaban is an excellent alternative given its once daily. Going by the much we know, option A is totally out of it because these agents are not as effective as warfarin in preventing thromboembolic events in patients with AF as in mechanical valves. They are not effective in mechanical valves. I think some of these drugs are excreted through the renals. Some are through the liver. So I don't think that B is correct. For D, for patients whose international normalized ratio levels on warfarin have varied due to non-compliance, rivaroxaban is an excellent alternative given its once daily dosing. I think I'm comfortable with that D. I'm not very sure of the C. More opinions, please.
Well, I think that that's up A. It's not just that there was an answer you were trying to give, but I don't think that is actually it. I don't think enough minds controls this. When you are thinking in terms of mechanical heart valves.
Okay.
Yes, I think for now, it is when there is a valvulopathy or when there is a mechanical valve, it is warfarin that is that the guidelines recommend. I do not think that they have done enough randomized control studies to demonstrate the efficacy of these other drugs or their superiority over warfarin. Then, yes, I think each of these drugs can be used safely. That is not true because I think possibly apixaban might be used in low doses, but I think generally they keep saying that NOACs and renal failure, they don't want to use them. But I've also had nephrologists say that low dose, I think like 2.5 milligrams of apixaban can be used.
Yeah,
And
I'll enter.
so,
This is the always
sorry,
anything
sorry.
for free every day. Say go, you dey clean am. When they cook with good.
Please continue, sir. Those are interference.
Okay, fine. Then I think
Come on, if you don't clean that kitchen or this salon, they'll be cooking themselves.
Sorry for the interruption. I've muted them. Thank you.
Okay, thank you so much. The option C, I think is true. Idarucizumab, is that not what you use to treat the dabigatran toxicity?
That's the antidote, actually.
Yes,
I recall.
for dabigatran. Then
Yes.
the issue of this option D that says for patients with international normalized ratio, well, most of the NOACs, they don't have long half-life. Most of them tend to be given a BD, so you don't even use it for issue of compliance. It has superiority over warfarin in other areas in terms of you don't have to measure the what is it called? The drug level, all those ones. You don't have to less drug, less drug food interactions. But when it comes to terms of compliance, no, because you still have to use most of them BDs. So I think the option that is correct is C.
Yeah, C is actually correct. But is rivaroxaban BD?
Rivaroxaban,
No,
they told it,
rivaroxaban is daily.
It's daily.
but for the first three,
Rivaroxaban is daily. For the first 21 days, you give a
yes, the
higher
first,
dose. After
yeah,
21 days, you lessen the dose.
those.
While apixaban, for the first 7 days, you give a higher dose, BD. After 7 days, you lessen the dose. Then yes, what he was saying about advanced renal disease, once the creatinine clearance is less than, I've forgotten the value, you give 2.5.
Yes, around 30.
It's 30.
It's 30.
Yes.
But that's for rivaroxaban, right? But apixaban, they not say apixaban is safe in renal. I think that's the only one that is safe in renal disease. All others, you have to renal dose.
Apixaban is safe, but still you reduce it to 2.5 BD.
Yes,
in renal.
Yes.
Then to add to it, antidote of the other ones, rivaroxaban and apixaban is Assessemt.
Okay.
Sorry, I have a contribution to make. I just want to clarify the question. The question said atrial fibrillation. So when we're talking about rivaroxaban 15 BD, we're talking about it in treatment of thromboembolic syndrome. That's DVT or PE. But when you're trying to treat atrial fibrillation, I think the dose of rivaroxaban statin is 20 milligrams. I could be wrong, daily. Since you're not treating anything, you are just using it as a prophylaxis, right? So
I think you're right. You're right in what you're saying.
Yeah.
For prophylactic dose is different from when you're actually treating. So you're right in what you're saying.
Thank you very much for all the contributions and all the directions.
Sorry, and if I'm not mistaken, I think the 2.5 is indicated in peripheral artery disease. That's revealed to ban. There's a 2.5 milligram rivaroxaban for peripheral artery disease.
Okay. Okay.
In addition to antiplatelets and statins, I think we can check that. Then apixaban, even at the continuation phase when the dose is reduced, it's a BD drug throughout its treatment for all indications.
Thank you very much.
Then also in addition for apixaban, patients greater than 80 years, they would benefit from 2.5 milligrams as well. And also patients less than 60 kilograms, they would also benefit from reducing the dose of apixaban, aside having a renal dysfunction. Thank you.
Particularly apixaban. Okay, thank you very much. Question number 75. A 73-year-old woman with exertional angina is referred for a standard Bruce protocol exercise tolerance test with thallium-201, single photon emission computed tomography. Her nuclear images are shown in figure 1.18. What is likely diagnosis? This will not allow us to use their nuclear medicine this night. Image 1.18. Can you help us project it? Okay. Okay. What is the likely diagnosis? A, dilated cardiomyopathy. B, single vessel coronary artery disease involving the left circumflex artery. C, prior inferior myocardial infarction with high grades stenosis of right coronary artery. D, left main of severe multivessel coronary artery disease. E, normal coronary arteries. The images demonstrate breast attenuation artifacts. Opinions, please. Dr. Jai.
Hello, sir. Yeah, I'm here, sir. So if we look at the pictogram, we'll see that for the stress, the R1, yeah, we see that for the stress, we see that it appears that when you compare it to the rest, which is immediately below it, if you look at those two horizontal, pictures, you find out that the cavity for the stress, yeah, if you move especially towards the last 3 or 4, find out that the cavity on the stress appears to be larger when compared to that of the rest. And the same holds true for most of all the other frames that are shown. So it appears that cavity dilatation occurs in this patient immediately, either with the stress or immediately after the stress. And from what we know of coronary diseases and the imaging associated, we are told that if a patient demonstrates cavity dilatation under such circumstances, then it is a pointer to extensive coronary artery disease, and it is typically left main disease or multivessel disease. So for this patient to be showing increased cavity dilatation, then what would come to mind is that this patient has extensive coronary artery disease, either multivessel or left main disease. So if we go back to the options now, I hope all of us can appreciate the cavity dilatation.
Yeah, I think fairly, yes.
Excellent. So if we now go back to the questions and we now see whether we can, what we can agree or disagree with. So the question says, dilated, what is the likely diagnosis? Dilated cardiomyopathy. I don't think that is true because if it were dilated cardiomyopathy, in contradistinction to extensive coronary artery disease, I would expect the cavity dilatation to persist with both stress and rest. But that is, the dilatation is isolated only with the stress test here. Then single vessel coronary artery disease involving the left circumflex. Single vessel doesn't, I don't remember reading that single vessel disease causes such dilatation. And even if it's weaker, if we look at this picture, we do not see defects in the lateral aspect, the lateral wall. I do not see any perfusion defect. So I'm not buying that. So what other options are there? Because the only thing that is notable here is the cavity dilatation. For me, that's the only thing I appreciate. So the C says prior inferior myocardial infarction with high-grade stenosis of the right coronary artery. Prior. If there is a prior, excuse me, then I will still also expect that there should be a perfusion defect, irreversible perfusion defect, like possibly. But I don't have any convincing picture here that there is a persisting, because if you are saying that the myocardial infarction means that the cardiac tissue is necrotic, it dies. I don't see anything convincing me about that there. So I'm also not buying that option. So what is option D? Can we say option D and E? Thank you. Left main, D is what I would readily opt for. Then E says normal coronary arteries. It can be normal coronary arteries in the context of a cavity dilatation occurring after exercise. So for me, option D is the most viable option.
Thank you very much, Dr. Ajayi. Any more contributions, please?
So I just dropped an article on the WhatsApp group that kind of gives an overview of this nuclear imaging. We can look at it later. Thank you.
Thank you very much. Very much thanks.
So once we confirm, and if there are no other options, once we confirm that the option is true or false, then we fire on.
All right. Question number 76. Which of the following statements regarding pulses alternance in patients with marked left ventricular dysfunction is true? Pulses alternance with marked left ventricular dysfunction. It is usually associated with electrical alternance of the QRS complex. It is less readily detected in the femoral compared with radial arteries. It cannot be detected by non-invasive sphygmomanometry. it can be enhanced by assumption of erect posture. It is uncommon for patients with pulsus alternans also to have an S3 gallop. Opinions, please.
Well, what I know is that pulse alternans of severe myocardial dysfunction, and is different from electrical alternance, which we normally see in the context of pericardial effusion, large volume pericardial effusion. So to say it is usually associated with electrical alternance, that is not true. It is less readily detected in the femoral compared with the radial arteries. This English now, it is less readily. That means you wouldn't assess it, you wouldn't appreciate it better in the femoral compared with the radial arteries. Let me save that one and go to the next. It cannot be detected by non-invasive sphygmomanometry. It can be detected. So that option is false. It can be enhanced by the assumption of erect posture. Let me also save that. And then it is uncommon for patients with pulsus alternans also to have an S3 gallop. Uncommon, no, because left ventricular dysfunction is usually associated with a third heart sound. So I don't think this option is also false. So the option comes down to between B and is between B and D. So let's rationalize further. For B, it is less readily detected. It can't be true, because if I'm feeling for the pulse in the femoral and in the radial, I think the femoral is supposed to give me a better indicator of myocardial performance compared with radial artery, I think. So if I'm to take, I would opt for D, just because I'm not too comfortable with this B. So I don't know, please, contributions and comments.
My concern with B option is that they say it is less readily detected in the femoral compared with the radial arteries. Because if you're having pulsus alternans, you should be able to pick it both in the radial and in femoral. Except there is a peripheral artery disease again that is superimposing on this. It is no more exclusive a cardiac disease. So the issue of option D really stands out more than the B option. My thoughts, though.
Yeah, because if you are thinking in terms of a good myocardial function, then I think the femoral should be more representative than the radial. But I don't know. Let's hear what others say and then we check the answer.
I think we've trashed it already, Dr. Ajayi. You have really given us the answer, because you said that the femoral, you should be able to palpate it more in the femoral than in the radial artery. So if they say it is less readily detected in the femoral, that is false, because you are looking for the true answer here. So the true answer should actually be, it can be enhanced by the assumption of erect position. That's the only one that we have not nullified.
Yeah, but do we have what explanation is given? At times, so this English can be twisty, can be confusing. That's so what answer? What
because
reason?
in the femoral artery, it gives more volume than even the radial. If you can't palpate maybe pulses in the radial, you go to the femoral because it's larger than the radial, really. just like the brachial is larger than the radial. So you expect to be able to appreciate pulses more at the femoral compared to other peripheral pulses. Seems to be the largest. So that's just it, and it's logical. So you should feel it more in the femoral, then the brachial, then the radial. So it should be the other way around, not less readily. It should be readily by the femoral than the radial.
Exactly. I think, yes, I think I agree with that. I agree with that. So please, let's confirm that it's B, then we fire on.
That's wonderful. I think D is the answer. We'll move on then.
Sorry, did you say B or D?
D as in dog.
All right, thank you.
Thank you.
I think do.
Sorry?
No, I was just joking. That D as in dodo.
Okay. Yes. All right. Question number 77. Which of the following statements regarding exercise testing is true? Exercise testing. A. Frequent ventricular ectopy in the early post-exercise phase predicts a worse long-term prognosis than ectopy that occurs only during exercise. Patients who develop QT interval prolongation during exercise testing are good candidates for IA antiarrhythmic drugs. Okay, 1A antiarrhythmic drugs. The appearance of sustained supraventricular tachycardia during exercise testing is diagnostic of underlying myocardial ischemia. D. Exercise-induced left bundle branch block is not predictive of subsequent cardiac morbidity and mortality. E. Tachyarrhythmias are commonly precipitated during exercise testing in patients with Wolff-Parkinson-White syndrome. Exercise testing test. Who could answer, please? Exercise test. Exercise test.
Okay.
Well, the ones
Let
are
me.
okay. Good. Please go ahead.
All right. Let's take a look at it all together. Make sense of this with some cardiology basic principles. If we look at option B, patients who develop QT interval prolongation during exercise are good candidates for class 1A antiarrhythmic drugs. Yes, in under stress, we expect that the normal response to exercise is that this QT interval is decreased. But this time around, it's an abnormality. It is instead of decreasing, it is prolonging. Why would you give class 1A antiarrhythmic agents in these patients in rest? We don't have any information with respect to their baseline ECG. So I don't think this is a safe option for us to
Chief, please, your voice is a bit low. Just
okay.
Please. Yes.
Sorry.
Thank you. Thank you, sir.
I'm audible now?
Absolutely better now.
Okay, thank you. I said in option B, patients who develop QT interval prolongation during exercise testing, they said they are good candidates for class 1A antiarrhythmic drugs. It is true in normal physiological response, in normal we expect a QT reduction. So this time around, we're having QT interval prolongation. We don't have any baseline QT interval. So I don't think it's giving them class 1A and B. That not see
I don't
the
I
appearance.
don't know I don't know whether others are hearing you, sir, but I don't know. Maybe it's my own network or whether it's sorry, please, could you repeat the last sentence you made?
Okay. Can you hear me now?
Yes, I hear you loud and clear now, sir.
Okay. I said for option B, patients who develop QT inflammation during exercise is actually an abnormality. What we expect in exercise is that the QT interval is supposed to be shortened normally. But in this instance, there is a QT prolongation. Yes, is an abnormality, but we don't know what is their own baseline QT interval like. Is there a baseline QT prolongation? So I don't think it's safe for me to start giving them anti-arrhythmic medications class 1 simply because in a QT interval prolongation under stress. So that knocks out option B for me. Am I still audible?
Yes, I can hear you.
Okay. Now, option C, they said the appearance of sustained SVT during exercise testing is diagnostic of an underlying myocardial ischemia. That is not true. Absolutely is not. Yes, we can have in exercise normally, we can have SVTs. It is when we are beginning to have ventricular tachycardias. That is when, yes, it's a problem. But with increasing workload, it's normal to have SVT. But sometimes you can even have significant premature atrial contractions. So that knocks out. Exercise-induced left bundle branch block is not predictive of subsequent cardiac morbidity and mortality. That is also not for me. I wouldn't. Then tachyarrhythmias are commonly precipitated during exercise testing in patients with WPW syndrome. So what I'm not sure about is option A and option E, but I'm suspecting that the increasing workload, the conduction through the accessory part is likely to be suppressed. I'm not sure. I'm not sure really about it. So
are you using an earpiece, sir?
I'm not using an earpiece. I'm using directly to my system.
Okay, I'll attribute it to my own distance. Sorry, please fire on, sir.
Sorry, it's having challenge hearing me. So
Dr. Sir, I think you should log out and log in.
go okay.
Okay.
You keep breaking, like we can't hear you well.
Oh, okay. So I'm not the only one.
No, you're not the only one, sir.
Okay. Or maybe perhaps let me just get the earpiece. Sorry, just a minute. Meanwhile, you can continue while I take me like 2 minutes.
Okay, sorry, I don't know, but I don't know whether it will help to rule out option E. But I know that they said they don't like exercise stress tests in patients that have baseline Wolff Parkinson White. Instead, you prefer pharmacological stress tests. So I don't know whether this will help in ruling out E. Not sure. Then for option B also, aside what Dr. Sarah said, when I saw the option, why I think is a false is that normally class 1A antiarrhythmic drugs prolong QT interval by blocking sodium channels. So why would you want to further worsen the QT prolongation? That's my contribution or my comment.
Yes, indeed. Yes, indeed. Thank you. Yeah, that's you've just given me the clarity on that option B. Yeah. The explanation you gave. Then I also remember that the option E, Wolf Parkinson White, during exercise, the conduction during exercise can be different from at rest. So during exercise, conduction then occurs through the AV node. I think, if I remember, it occurs through the AV node. And, you know, in Wolf Parkinson White, it's a congenital situation in which there's an accessory pathway. So during exercise favors conduction through the AV node. And so that removes the issue of the delta waves that makes them predisposed to the delta waves that occur during the conduction through the accessory pathway, which makes them prone to arrhythmia. So this option E, that says tachyarrhythmias are commonly precipitated during exercise testing in Wolf Parkinson White, that is not true. That is not true. And we want the true option. So exercise-induced left bundle branch block is not predictive of subsequent cardiac morbidity. It is predictive. It's very predictive. If the patient is having LBB during exercise sessions, such patients can progress to having LBB even at rest. And we know that LBB is a marker of increased morbidity and mortality. So that option is false to say it is not predictive. So those last two are out. The appearance of sustained supraventricular tachycardia during exercise is diagnostic. He said something about that it is not. So the last three options seem to be false. Patients who develop QT interval prolongation during exercise testing are good candidates. From what you said, they are not. So frequent ventricular ectopy in the early post-exercise phase predicts a what? So the most reasonable answer seems to be in the early post-exercise phase. That seems to be the most reasonable, because what we are saying is that the patient is having frequent ventricular ectopy immediately following exercise, maybe within the first 3 to 5 minutes. During exercise, ectopy may occur, but if ectopy is still occurring in the post-exercise period, I think that gives room for concern. For me, this option A seems to be what holds the greatest appeal.
Okay, am I audible now?
Very
Yeah,
audible.
Okay. Yeah, I think.
Yeah, okay. Let me just add.
Okay, go ahead, please.
Sorry, please continue. I'll
No,
speak after you. Okay, for class 1 antiarrhythmic drugs, all of them are sodium channel blockers. What makes class 1A unique among them is, in addition, they block potassium channels. So they're both sodium and potassium channel blockers. So this is why they prolong QT. And in particular, class 1A antiarrhythmic drugs are to be avoided in patients who have pre-existing QT prolongation. Thank you.
Okay, so evidently, I think our most likely answer should be A.
Okay.
Because
so let's add something to that question again. That option C, I want all of us to note that SVT can actually happen in normal individuals when they are undergoing exercise testing. So SVT is never diagnostic, just to emphasize that it's normal. Thank you.
yes, the appearance of SVT during exercise, in fact, it's normal. The only thing, is when you begin to see ventricular tachycardia, VTs. But you can have occasional premature ventricular contractions. It's also normal. That is of no significant consequences. But by the time it becomes sustained, yes, it's, in fact, sometimes they will even tell you that is an indication for you to stop that stress test immediately. Otherwise, the patient is just going to deteriorate and continue going. So what makes option A for me the answer here, because it's really, really a marker of poor prognosis, because this is post-exercise and it is even early on that we're beginning to have frequent ventricular. So in the recovery phase, where we're expected to start seeing normally a resolution of whatever ECG changes you have, and with good chronotropic response, also the reduction in heart rate and also the blood pressure returning almost back to baseline. And we are now seeing frequent ventricular FPs. That's, I think, is a red flag sign. Should be our answer. Thank you. Hello.
We hear you, sir.
Okay. I think I'm done with my.
Sorry, got a little distracted. Yes, thank you for all the explanations and all the inputs. I think the answer is actually A, that the frequent ventricular ectopics in the early post-exercise phase predicts a worse long-term prognosis than ectopy that occurs only during exercise. In absence of further contributions, I think we'll move on. Please. Question number 78. Which of the following statements regarding extrasystolic sound is true? Extrasystolic sound. Ejection sound are high frequency click that occur in mid-late systole. Ejection sound associated with pulmonic stenosis decrease in intensity during inspiration. Aortic ejection sounds vary with respiration, occurring later in systole during inspiration. The bedside maneuver of standing from a squatting position causes the click of mitral valve prolapse to occur later in systole. Contributions, please.
Well, I think we know that ejection sounds are, yes, they're high frequency clicks, but ejection sounds, they are early systolic, not mid-late systolic. They are early systolic. So this option A is false. The ejection sounds associated with pulmonic stenosis decreases in intensity during inspiration. Let me keep that one. Then aortic ejection sounds vary with respiration. Vary with respiration. No, it is the one on the is the ones on the right side that are affected by respiration. Aortic is left-sided. That's the way I reason that. So that is also false for me. The bedside maneuver of standing from a squatting position causes the click of mitral valve prolapse to occur later in systole. Okay, so patient was squatting initially, then is standing. So that would lead to a reduction in, because I know when the patient is squatting, there is increased preload, as was said earlier. So with standing, there would be a reduction in would I say venous return? And with that, it means that the amount of blood that is getting into the heart per unit time would not be as much as when the patient was squatting. So if there is less blood in the, if there is less blood, I'm trying to reason how I understood this thing before. If there is less blood in the say it is from the left ventricle, no, mitral valve. Okay, so blood comes into the to the left atrium, then flows through the mitral valve, and there's reduced blood now coming in because the, so it means that the click should occur earlier, because this click occurs when there is I'm trying to explain the way I understand it, but there is a deficit I'm trying to bridge. I know that this change in posture causes a reduction in volume return to the heart. If there is a reduction in volume return to the heart, that click of mitral valve prolapse will occur earlier. If there is an increase in blood flow, then it will occur later. I don't know how to better explain it. Maybe someone can help me please. So for me, this this option D is not true.
It is okay.
Go earlier. Okay, please, contributions.
Hello, am I audible?
Yes, you are.
Please, you are
audible. I think what you explained, my opinion, I think you're correct. I also think B is the answer, because I remember there's somewhere I came across that, if you recall, there's this Swiss general times, they say all events on the right side increases with inspiration. However, except in pulmonary stenosis, whatever happens in pulmonary stenosis is the inverse of whatever else that we're seeing in other things that occur during inspiration. So it is true, the ejection sound in pulmonary stenosis decrease in intensity during inspiration. Another instance, let's say maybe for instance like tricuspid stenosis, you expect that in inspiration it's going to actually increase. But in pulmonary stenosis, it's a decrease that we actually going to be expecting. So B is the answer. And your explanations, I think, quite agree with them. Thank you.
Yes, I think that that mnemonic is right. Right-sided heart sounds are increased with inspiration, whilst left-sided heart sounds increased with expiration. And from what you said, with the exception of pulmonary stenosis. So I think B seems to be what we are targeting, although I was just trying to be sure that I got my analysis right with this option D. But I think the option, if you've checked it, then any contributions? If there are no contributions, then I suggest we fire on.
I think we should proceed.
Dr. Ozuke, please, are you still there?
Good evening, Jerry. Yeah, I'm here.
Okay.
Thank you for the contributions on question 78. I'll thank you for the mnemonics. Everything in the right increases with inspiration except pulmonary stenosis. And the opposite is true for the left, even though we don't know the exception in the left anyway. He didn't tell us how the exception in the left. Without question 79.
Maybe there are no on the left.
Sorry? Maybe there is not in the left. Wow, the network seems to be funny though.
To the best of my knowledge, I do remember coming across any other exception.
Okay, okay. Thank you very much. Which of the following statements regarding the ECG in chronic obstructive lung disease with secondary right ventricular hypertrophy is correct? The mean QRS axis is typically less than 15 degrees. Less than 15 degrees. The amplitude of QRS complex is abnormally high in precordial leads. Even mild right ventricular hypertrophy produces diagnostic electrocardiographic abnormalities. Its wave in V6 is typical. Precordial lead transition is typically rotated in the counterclockwise fashion. That's early transition. For me, if I can make a comment here before I can just, the flow goes on, is that we know that for left ventricular leads and the right ventricular leads, in the left ventricular leads, the S wave represents the R wave of the right ventricular leads and the vice versa. So that makes D quite appealing. A deep S wave in V6 is typical. Then option A, the mean QRS axis is typically less than 15 degrees. But for me, this looks a little ambiguous because we don't know whether it is minus 15 degrees or plus 15 degrees. Then if it is plus 15 degrees, I think that should be within the normal axis, which is from minus 30 to, I think, is it 90 or thereabout? Then the amplitude of QRS complex is abnormally high in the precordial leads. Of course, it can be not the precordial leads. That is not correct. Because even V6 is equally a precordial lead. Option C, even mild right ventricular hypertrophy produces diagnostic electrocardiographic abnormalities. Not yet decisive on that. Let's still hold on that. And then when we go to E, precordial lead transition is typically rotated in a counterclockwise fashion. That's early transition. I can't be very emphatic on that, but I think D is the most appealing, clearly most appealing for me here. More opinions, please.
Well, thank you so much. But I just want to call attention to there have been two in one questions there. So we should not miss out chronic obstructive lung disease. So we are looking at for ECG features of chronic COPD, as well as complication, which is the right ventricular hypertrophy. So just like he said, the KRX as is either way, even if it's minus or it's plus, that would be false. Because if it's minus 15, that is a left axis. And if it's plus 15, it is if it's minus 15 rather, it is it's a normal axis, but it's like on the left side. That's up. That's what I meant. Then if it's plus 15 too, it's still within normal. So whichever way, it will be a negative. Then the amplitude of the KRS is abnormally high in the precordium. We are talking of COPD here. We expect to have low voltages in this context. So it shouldn't be high in this context. So I think that should also be a false. Then even mild right ventricular hypertrophy produces diagnostic electrocardiogram abnormality. That would be a false because, you know, we need maybe if it's just a mild right ventricular hypertrophy on V1, we might actually not see, it might just be equivocal. That's the usual.
I don't know if from my end, that's your network, your network.
Oh, you're not hearing me?
Wow.
Okay. Can you hear me now?
You can.
Okay. I said for C. C says even mild RVH produces diagnostic ECG abnormalities. I think that too would be a false, actually, because we know if it's just mild, with in the setting of a COPD now, we might just have it as equivocal, so we might not be able to really say if there is actually RVH or not. So that's, I think, should be false. Then D, a deep S wave in V6 is typical. Yes, a deep S wave V5, V6, as well as in other lateral leads, leads 1 and AVL should are part of the criteria for LVH, for RVH rather. So I think that should be the correct answer. Then they said precordial lead, that's E now. Precordial lead transition is typically rotated in a counterclockwise fashion. That's early transition. Well, I feel that one would be false because talking about early transition, the transition, let me say leads, where we look out for the transition leads should be leads V4 now. So if we are talking of early transition, not necessarily, because it's possible to have a right ventricular hypertrophy without an early transition still, meaning that you can still have a normal transition between V3, specifically V4, even in the setting of an RB or a RVH, as the case may be. So I think the most suitable should be D with those explanations. Thank you.
Thank you very much, Dr. Orimolade. Dr. Ozuke. Okay. Okay, maybe Dr. Ozuki has network. I agree that your explanation, I agree with your explanation, and the answer confirmed is D. Kindly permit me to continue until Dr. Ozuki comes back on. So we'll move to the next question. Question that should be 8C. Which of the following statements regarding shunt detection is true? Option A, when an anatomic shunt is present, arterial oxygen saturation normalizes with administration of 100% oxygen. Option B, methods of shunt detection include oximetry, echocardiography, MRI, but not radionuclide imaging. C, among the sources of right atrial venous blood, the inferior vena cava has the lowest oxygen saturation. Option D, due to the low sensitivity of oximetry for shunting detection, most clinically relevant left to right shunt cannot be detected using the method. Option E, the FLAMS formula is used to estimate and mixed venous oxygen content proximal to a left to right shunt at the right atrial level. Okay, so I'll be attempting to answer this. So for option A, when an anatomic shunt is present, arterial oxygen saturation normalized with saturation of 100% oxygen. I don't think that is true. There's already a shunt, so giving oxygen does not mean that the saturation will go to 100. It's like that you are just augmenting whatever level of desaturation or hemoglobin carrying oxygen in the blood, but I don't think that will be able to get up to 100. So I think that is a false. Option B says method of shunt detection include oximetry, echocardiography, MRI, but not radionuclide imaging. I think that is also false. I think radionuclide imaging is part of what is used to detect shunts. I think that's should be part of it. Option C, among the sources of right atrial venous blood, the IVC has the lowest oxygen saturation. This question looks somehow. The IVC has the lowest oxygen saturation. I think this is also false. Number one, because of the way the question was phrased, and then because of the way the option was phrased, and then because I think I've come across somewhere before that that the IVC does not have the lowest oxygen saturation because the renal uptake of oxygen is low, but I can't really remember the explanation very well, but I think I've read it in the past. So I'll be needing help with that. Option.
Then based on the explanation Prof gave us too, that the brain utilizes more oxygen. So the SVC has the lowest compared to the IVC. So it can be right.
Okay, thank you so much for helping me out. Then option D, due to low sensitivity of oximetry for shunt detection, most clinically relevant left to right shunt cannot be detected using this method. I don't think that is right, but I'm not sure whether oximetry actually have a low sensitivity. At least it will give us an idea. But that's my thought. Option E, I'm not too familiar with that formula. So I think for me, maybe option E. I don't know. So please kindly help. Thank you.
Okay, thank you, Dr. Adeoju. E is correct. If you remember my presentation, I talked about Planck's formula that is used for estimating mixed venous oxygen content. That's the 3 SVC plus IVC divided by 4. So that's what is used. And if it's a left to right shunt, you take blood before the shunt. So you take blood at the level of the right atrium.
So that was
Thank
the
you so much.
FLAM formula.
Yes, that's the FLAMS formula.
Oh yes, that's true. You mentioned it. Thank you. Is any other
And
contribution?
also, we should not forget, just like Prof said yesterday, if patient has maybe anomalous loss or absent something about the inferior IVC, so that formula would actually change, if we remember, in case they bring it out.
Thank you.
Yeah, so it won't be over 4, it will just be over 3.
Yes.
I think you can just go on. My network is acting up here now. Been
We
logged out
noticed.
for 3 or 4 times repeatedly.
Yeah, we noticed. Thank you.
Thank you very much there.
Yep.
So I just need to add that option B, I think the mnemonic I had was more, M-O-R-E, because all those options listed are actually used in the assessment, in the detection and evaluation of shunts. M for magnetic resonance, O for oximetry, R for radionuclide, and E for echocardiography. So all the 4 are actually used for shunt detection and evaluation.
Thank you so much for that, Monique. Okay. Any other comments before we move to the next question, please? Electrocardiographic lead V1. Okay. A, right ventricular hypertrophy. B, with Parkinson-White syndrome. C, Duchenne muscular dystrophy. D, left anterior fascicular block. E, misplacement of the chest lead. I think this is looking for right ventricular hypertrophy. Of course, there will be a prominent R wave. I think it is also in Wolff Parkinson-White, which is true. Of course, in misplacement of the chest lead, there will be a prominent R wave in V1. In left anterior fascicular block, I don't think so. There's no prominent R wave, but I'm not sure of Duchenne muscular dystrophy. So for me, okay, but if I look at it very well, I will be between C and D, but maybe I'll pick D. But I don't know. Anybody with clarifications, please? Thank you.
Well, I'll also go for D. This seems the most logical here. However, in case they twist it somehow, for Wolff Parkinson-White, the regular one that we see often, the commonest one will be the one with predominantly R wave in lead V1. Sorry, S wave in lead V1. That means the accessory pathway will be on the right. However, if the accessory pathway is on the left, that's when we'll have a prominent R wave. We have type 1, type 2. Or is it type A, type B now?
They use A and B, they use 1 and 2.
So yes, so if you have the accessory pathway on the right, it will be the usual one that will not be R wave. That means there will be a prominent S wave in the V1. But if you have the accessory pathway on the left now, then we'll have a prominent R wave. That means there will be positive deflection on V1. So that's just in case they now put type A or type B in the options. So we'll know that. But I think D is the most left anterior fascicular block. We don't see any S wave in R wave, I mean, in V1.
Yeah. Thank you very much.
And sorry, can we also see it in this way, like how I'm saying it, like all of these are causes of right axis deviation, except left anterior fascicular block, because left posterior fascicular block is cause of right axis deviation. Hello, are you hearing me?
Please increase your volume.
Oh, okay.
Yes.
You hear it now?
Yes, it's better.
Okay, so how I'm seeing this, that's from my own angle. When I looked through the options, all of these are causes of right axis deviation, except left anterior fascicular block, because left posterior fascicular block is the cause of right axis deviation. As in, I'm seeing it in that aspect, because every other thing here causes right axis deviation except D. So if it was left posterior fascicular block, I think it would have gone for it. That's looking at it in this angle I'm talking about. I don't know if it's a good contribution to it.
It surely is. So checking the answer. The correct answer is D. Yes, please. Dr. Briggs, are you saying something again? You wanted to say something?
No, I'm not. I'm not saying anything. Okay, thank you.
Thank you. The correct option is B. So we are correct. We move to the next question if there are no further comments. Okay. 82. The hemodynamic tracing illustrated in figure 1.19 is associated with each of the following features. Okay. Option A, advanced valvular aortic stenosis. Option B, a bifid aortic pulse contour. Option C, normal left ventricular end diastolic pressure. Please, can we see option D and E if there's any? Okay. Option D, a delayed rise in the carotid artery pulsation. Option E, expected clinical improvement with transcatheter aortic valve replacement. Okay, so I have to confess here, I need people that are versed with this hemodynamics to actually help out, although I can actually try. So for the hemodynamics, the red tracing are showing the left ventricular cavity pressure during catheterization, and the blue tracing are the aortic waveform during catheterization. So what else do I remember? I can't recollect the orders very well, so please, I need help here. Anyone that have a better explanation for the
I'm not really good at hemodynamics too, but I will give a try from our echo.
Thank you.
If we look, okay, just like you have said, the left ventricular mid cavity, that's the red, then the aorta is the blue. So if you notice that initially we have the pressure gradient in the left ventricular mid cavity was as high as 180 at a time, the first 3 cycles. Then that for aorta was around close to maybe 90 something or 100. Then subsequently, that's the later 3 cycles now, we saw that the tracing sort of equalized in such a way that there is a drop in the tracing as you advance, maybe as you advance the catheter. That's what I would say. So when the catheter is in the left ventricular mid cavity, and it drops as much as almost 180 minus 100, that's like 80 millimeters of mercury when the catheter was advanced to probably the left ventricular outflow tract in the later 3. That drop is really significant, and I think we see that in HCM. That's an occum obstructive where we have intracavitary gradients. Anything greater than 50 millimeters of mercury will be classic for an obstruction, demonstrating an obstruction at the left ventricular flow tract. So I think this tracing is demonstrating obstruction at the left ventricular flow tract in HCM. As against if it were to be a valvular abnormality, we expect the gradients both at the mid cavity as well as the outflow tract to be the same. So if it's high all through. There should not be intracavitary gradients. And like I've said, you should note if it's greater than 50, you know that demonstrates obstruction in occum. So having said that, now you should try and answer the question. So option A says advanced valvular aortic stenosis. That would be a false, because we said this in advanced aortic stenosis, we expect that the pressures will be equal. We don't expect a gradient. Then B, a bifid aortic pulse contour, which I think is even demonstrated here with the blue line. we can see that there is bifid upstroke, like a bifid, which is what we see in HCM as against if it were aortic stenosis. Aortic stenosis would be like a is a gradually rising or slow rising this thing. Some have like a sharp a notching or a diacritic pulse waveform. So I think B should be correct. Then option C says normal left ventricular L diastolic pressure. That's obviously is wrong because we have demonstrated increased gradients at different ends. Then for D, a delayed rise in the carotid artery pulsation. That would be more for stenosis and not for HCM. So that makes that false too. Then E, expected clinical improvement with transcatheter. Okay, since it's not a valve problem, it's a dynamic problem. So I think that one too will be false. Thank you. For maybe if there's any other person with more clarification. Thank you.
Thank you so much. Okay.
Oh, is Prof around?
I'm just checking whether Prof is around.
Okay.
Good evening, Prof, sir. Prof, sir, thank you for joining us tonight.
Good evening, madam.
Yes, sir. Good evening, sir. Thank you for always joining us, sir. Sir, we need more clarification with this characterization waveform, sir.
Yeah, so thank you. I appreciate the explanation given so far. It's fantastic explanation. So,
Prof, thank you for coming around, sir.
Good evening. God bless you, sir.
Thank you, sir.
God bless you, sir. So, this catheter, there are two catheters here, right? So, one in the red catheter, that means in the LV cavity. The blue waveform is a catheter in the aorta. So, they're comparing both pressures at the same time. We expect that the peak systolic for LV should be equal to the aorta if there's no obstruction. Abi? If there's no obstruction anywhere, the peak for the LV, which is red color, should be equal to the blue peak, which is the aorta pressure. Yes, so just like you can see in the last three waves, you can see that the peak are both equal. That is what you expect. The last three shows that the peak pressure are both equal. Now, that's what we expect. So what we need to now tease out is what is happening in the first three waves. So you expect that you should look at the last three waves. Now the LV pressure is now far higher, right, than the aortic pressure. So it tells you that there is an obstruction somewhere. We all know that the pressure before the obstruction would be higher than the pressure after the obstruction. So that's what we create the pressure gradient. That's the difference between the two peaks. It's called the pressure gradient. Okay. So now that there's a pressure gradient between LV mid cavity and aorta, obstruction can be anywhere. Obstruction can be in the mid cavity. Obstruction can be at the aortic or at the aortic valve level, subaortic level. Anything, the obstruction is just from between either the mid cavity up to the level of the aortic valve. Okay, that's for the first three. So, but if you notice, the last three, they adjusted the catheter to the subaortic, right, to the subaortic valve or outflow tract. So at the outflow tract, the pressure was equal. at the outflow tracts. So as it was rightly said, it could be that probably there was a mid-cavity obstruction, which you can see in Okum, right? It could also be that they took this pressure during, it could also, as I said, the obstruction can be anywhere from the mid-cavity to the aortic valve level. So the obstruction can be at mid-cavity, at LVOT, or at the aortic valve level. That's looking at the first three waves. Now, they didn't tell us if they did any intervention in the before the next three waves. All we know is that the catheter position was changed for the last three waves, and we found out that the gradient was equal. There was no pressure gradient. So it could be one of two things. One, as I said, an obstruction anywhere from the mid cavity to the aortic valve level for the first three. It could be also that they were doing a procedure in which when they changed the aortic valve, either they were doing aortic valve transcatheter replacement of the aortic valve, and they now discover, so after that, the pressure now normalized for the last three waves. So that is what this tracing is depicting, that there was an obstruction in the first three waves. Thereafter, is either the catheter moved forward and there was no more obstruction at the LVOT and it was equal, or that they did something about the obstruction, which would likely be that they did a valve, aortic valve intervention. So I don't know what the answer is at the back, but this is what the tracing is telling us. So if they had put in the option that this stuff confirms mid-cavity obstruction, I would have gone for that. But they didn't say anything about mid-cavity obstruction in the options. The only thing I think was closest in the option is that they said they did an intervention and it now normalized.
Thank you
So
so
what
much.
did the answer?
They
I
said
don't really know.
B.
B.
Yes, sir.
That he has a bifid aortic pulse contour, right?
Yes, sir.
Okay. So the bifid aortic pulse contour. So what they're showing you is that on the blue peak. The only challenge here is they will have a bifid aortic pulse contour. I don't think that's really the real problem here because nothing has explained this mid-cavity obstruction. There's actually a serious gradient in this mid-cavity obstruction. Because this is the same aortic valve, aortic wave you expect. Sometimes they have that contour, dichotic notch on the peak of the wave.
Yes, sir.
I just think we should just recheck. But if that's what they said, no problem. But I think there is an obstruction in the mid cavity, and that either the obstruction was relieved or the catheter was moved away from the obstruction and the pressure now equalized. There's definitely something about that mid cavity. Okay. All right. So now what explanation did they give when they gave the answer? I'm sure they usually give an explanation.
Yes, sir. Dr. Sawa, can we go to the answer so that we can read it?
At least we can learn from the answer.
Yes, sir. Thank you. It's question 82.
Okay. Can you
Thank
see
you.
it?
Yes, sir. Thank you so much for navigating this for us. So it really does. The hemodynamic pressure tracing is consistent with hypertrophic obstructive cardiomyopathy. In the tracing, a large gradient exists between the mid cavity of the left ventricle and the aorta, as shown during the first three full beats. As the catheter
So,
is withdrawn,
so just
yes,
a
sir.
minute. So I
Yes,
just
sir.
want you to understand that statement. Remember, we said the first three waves show
Yes,
the
sir.
great serious gradient and is at the mid cavity. So anytime you're doing a procedure, that's what I would expect to see if there's an obstruction. So it's not something you should overlook. So
Okay.
well, they can have there is an MCQ, so maybe they can be looking for something else, but that is what that tracing is showing, that there's an obstruction. So the last
Okay.
tracing now shows that when you remove your catheter from the site of the obstruction, the pressure normalized. So that means you have left the mid cavity
Hmm.
that was obstructed. So that is how you confirm sometimes open during a invasive angiogram. Thank you. And continue so that we know what the answer.
Thank you so much, Prof. Okay. As the catheter is withdrawn into the subaortic left ventricular outflow tract, the gradient is no longer observed, just like we've been told now. Thank you so much, Prof, for your explanation. So I'll continue. In patients with valvular aortic stenosis, the pressure gradient will persist in the later location. I think that means that this is a fixed obstruction. So that means that the pressure gradient will be throughout. I think that's what that sentence means. Then a bifid aortic pulse
No, that's
control.
not what it,
Sir?
that's not what it means.
Sir,
That's
I'm
not what
listening.
it means.
Okay.
So it means that remember the obstruction is when you say aortic valve stenosis, that means at the valve level, right?
Yes, sir.
So it means that when your catheter was in the mid cavity first, you will see that gradient.
Yes.
If you now pull your catheter to the subaortic, remember you have not left, you've not gotten to the aortic valve.
Yes.
Subaortic still stenosis because it's a valvular stenosis, right? So you will still see the gradient.
Okay.
I want you to get it very well. Subaortic means that LVOT, that's outflow tract, right? The
Yes.
valve is still at the outflow tract. So if your catheter, so if the patient has aortic valve stenosis, if your catheter is still at the LVOT, left ventricular outflow tract, remember
Yes,
you're
sir.
still below the obstruction, right?
Yes, sir.
You still see the gradient because you are still below the valve.
Okay. I get that.
I need you to get that. So it's not because it's a dynamic obstruction. It's because the location of the obstruction is still high up. So it is
Okay.
until you leave the level of the obstruction, that is when the gradient will equalize. So if there is a valve level, that's why I said when we saw the first TV wave, I said the obstruction can be from mid cavity up to the valve level. So if when they removed the catheter from the mid cavity to the LVOT, it equalized, right? That means that they've left
Yes.
the area of obstruction. But if they were still seeing the gradient, even if the catheter is at the LVOT, then that means that the stenosis is still higher up. That means at the valve level. So until you move your catheter beyond the obstruction, which is beyond the valve, that is when the pressure will equalize.
Wow.
So
Beautiful.
that's why we do a tracing of the catheter to know the accurate location of the obstruction. Okay.
Thank you so much, Prof. Very, very clear. Thank you, sir. So I continue reading the answer. A bifid aortic pulse contour is demonstrated in the tracing with a notch on the upstroke called spike and dome configuration. and is characteristic of OCOM. This is in contrast to Dr. Sawa.
Okay. Can you see the screen?
Yes, yes, I can see.
Okay.
Thank you. This is in contrast to delayed rise of the aortic pressure tracing and therefore carotid artery pulsation, expected in patients with valvular AS. In addition, LV diastolic dysfunction is common in OCOM owing to impaired LV compliance, which leads to a prominent LVA wave and elevation of end diastolic pressure, as shown on the tracing. There is no role for aortic valve replacement in the treatment of OCOM. In selected patients with OCOM and severe symptomatic obstruction due to septal hypertrophy, surgical myomectomy or aqueous septal ablation may be beneficial. Thank you, everyone. Thank you, Dr. Sawa. Dr. Uzoke, your hand was up earlier. Your electronic hand, I mean. Okay. Question 83, please. Okay. A 53-year-old woman with a history of hypertension and obesity is diagnosed with triple negative estrogen receptor negative, progesterone receptor negative, HER2 negative left breast cancer. She undergoes echocardiography that shows a left ventricular ejection fraction of 65%, an average global longitudinal strain of minus 18.3%. She undergoes neoadjuvant therapy with I can't say that very well, paclitaxel and cyclastine. After surgery, she's treated with I can't say that very well. Sorry, I think the print. Can you please help me enlarge it a bit? After surgery, she's treated with adriamycin. Okay, thank you, sir. Total of 240 milligram per meter squared and cyclophosphamide. She undergoes updated echocardiography 6 months after the first echocardiogram and prior to initiating therapy with trastuzumab, that shows that an LV ejection fraction of 60% and a GLS of minus 14.4%. That's a drop in the GLS and the LV function. She has no symptoms or sign of heart failure. Her heart rate is 50 beats per minute and her blood pressure is 137 millimeters of mercury. Renal and hepatic function are normal. What will be the next appropriate step in management? Okay, option A, proceed with trastuzumab treatment plan. Option B, post-treatment plan, repeat echocardiography in 3 months. Option C, start carvedilol. Option D, start lisinopril. Okay, so for this patient, the pulse rate is already 50 beats per minute, so I won't. Let me see. Okay, let me just say what I know about chemotherapy-induced cardiotoxicity. I know that for the GLS, the average GLS is a little bit more sensitive than the left ventricular ejection fraction. However, both of them are good as early detection of cardiotoxicity in patients that have breast cancer and that's on chemotherapy. So if she has already been on some chemotherapy and then we notice a drop in the GLS and the ejection fraction, although still preserve ejection fraction, I don't think that I want to proceed with trastuzumab treatment plan. I think that's the wrong option. For option B, depending on the protocol of treatment, I'm not sure. For option B, they said post-treatment plan, repeat echo in 3 months. So for option B, I'm not so sure. It depends on the protocol of the treatment. I'm sure that we have oncologists, cardiac oncologists, and ministers that will help with this question. For option C, start carvedilol. I think that the heart rate is already 50 beats per minute. I'm not sure whether I want to start a beta blocker again. So I'm not sure of C. I'm not sure whether that's the most appropriate next step. Option D, start lisinopril. I'm not so sure whether that's the next appropriate next step. So please, I'll need help with this question. Thank you.
Okay.
Thank you, Doctor. Okay. All right.
All right. Sorry, can I go ahead? Hello, am I audible?
Yes, you are audible, Dr. Sawa.
Okay, thank you very much. Looking at this option, we're definitely not going to proceed. What would be the next appropriate step?
Sir, I think you need to increase the volume of your voice. I can't seem to hear you very loud and clear.
Okay, is it better now?
It's a little bit better, sir. Thank you.
Is it much better now?
Well, from my hand, I was to say a little bit better, but I don't know what others will say. It's maybe my network.
Okay. Yeah, I just want to ease out from the option. Looking at the approach already, I wouldn't want to give her. So I'm striking out. Her GLS, baseline GLS minus 10.3%, and after she started chemotherapy, it's reduced minus 40%, and the infection fraction from 5 reduced to 60. I think, not sure, will that be enough to pause her treatment? I don't know. Anybody has it better? I can just look up.
Well, Dr. Francis, I can barely hear you, but I don't know whether the others heard you.
Sorry. I don't know what's wrong with my earpiece.
Dr. Ajayi, did you hear me loud and clear? Maybe it's my network.
We didn't hear him.
Okay.
Hello, is it better now?
It's fantastic now. Thank you.
Okay, fine. I said I'm trying to tease out from the options.
Yeah.
Looking at her pulse rate of 50 beats per minute.
Yes.
I definitely will not want to give her carvedilol. I don't think it's wise to give her carvedilol.
Definitely not.
Okay, so, but again, if we go back and see her baseline EF was 65, she had a reduction of 5% from baseline to when she commenced the chemotherapy. Your data became 60%. Her GLS was at a minus 18.3% and reduced to minus 14.4%. Will that be enough for me to say we need to now pause her treatment, and on the basis of that, I'm not really sure. What I can obviously tease out is option C. I am not going to give carvedilol, and I think it's not correct to do that. But the rest, I don't know. I think probably anybody has a better information.
Thank you so much.
Okay, yeah, thank you. My definition of chemotherapy-induced cardiotoxicity is we have a definition for a patient in heart failure and a patient not in heart failure. Like, for example, we can actually have a patient who already is in heart failure and about commencing chemotherapy. So in such patients, we say if their left ventricular ejection fraction is 5 or more, like the difference is 5 or more in percentage, that patient already has a chemotherapy-induced cardiotoxicity. But if the patient was not in heart failure, that's pre-chemotherapy, and then you notice a sudden reduction in ejection fraction of about 10 and above, you say, okay, that patient has a chemotherapy-induced cardiotoxicity. But from this history given to us, the patient was not in heart failure before she started the chemotherapy. Therefore, the patient did not have a chemotherapy-induced cardiotoxicity because the reduction was just by 5%. But if this patient was in heart failure, I will say, okay, the patient actually had a chemotherapy-induced cardiotoxicity. So looking at the option, to stop, I'm looking at either A or D because the patient doesn't meet the criteria for her to stop the chemotherapy because the patient hasn't really gotten, does not meet the criteria for chemotherapy in this cardiotoxicity. Then again, to what is normally given to patients who are about commencing chemotherapy, they give them either carvedilol, a beta blocker, ARBs or ACIs, or maybe those vitamins because they act as antioxidants. So, but looking at this option, carvedilol is ruled out because the patient is already bradycardic. So, lisinopril will do a great job for this patient. So, if I'm to pick the most appropriate, I think I will go with lisinopril because by right, before we commence chemotherapy for any of these patients, they are supposed to be on lisinopril. They're supposed to be on an ARB, ACI, beta blocker, the vitamins, and there are some other drugs that we give. So I would go with D, but there are two options that are looking alike, like they are correct. Sorry, okay, A is saying proceed with, no. The answer is D, because there's no need proceeding with trastuzumab. The patient can still continue with an anthracycline, or because the patient was on, I think, anthracycline and cyclophosphamide, he or she can proceed with anthracycline because the patient doesn't meet the criteria for chemotherapy-induced cardiotoxicity. So rather, the patient will benefit from lisinopril because it is cardioprotective. So that's the little contribution I can give here.
It's not little, it's much. Thank you.
Okay.
Can I please say something?
Yes, please.
Okay. Thank you. Thank you, Dr. Briggs. But I will just introduce another perspective to this actually. Because if we look at the question very well, the GLS has almost how many percentage drop now? Is actually more than 15% drop. So the for cardiotoxicity using GLS, I don't know when this this book was actually published, but following by let me say definition of cardiotoxicity would be that and or, like you rightly said, either symptomatic or asymptomatic. So for patients who are asymptomatic, which this index patient falls into, GLS, drop in GLS more than 15% qualifies for cardiotoxicity. Although previously, any drop more than 15% means that, because what we normally say is that the GLS predicts reduction in left ventricular ejection fraction even before the patient actually develops symptoms. So this patient's ejection fraction is still normal and already has more than 15% reduction in GLS. He has had 6 months of the doxorubicin, that's the anthracycline already. Now want to go into the continuation phase with trastuzumab. That's where the issue is. And if it's still going to have trastuzumab and is a treatment that she must have, we have to protect the heart so that she doesn't become symptomatic or the ejection fraction does not eventually drop. So what we do for patients to prevent, either to prevent or to treat the toxicity, we need to give drugs like there's a dexamethasone, which is not in this option. Then you can also give beta blockers. Most specifically, carvedilol have been shown to help in this instance, and AC inhibitor, or if patient does not tolerate it, we give an ARB. So this patient needs to proceed to continue in the treatment for the cancer. So before proceeding, you have to protect the heart. So which of the drugs are we going to use is the question here now. So carvedilol trashed out. So that's why this D is correct, is the right answer here, in case they frame it in another way. Thank you.
Thank you so much.
Thank you so much, Dr. Molade. And looking at the answer now, the correct answer is D. Thank you. Please, can we move to the next question in the absence of further?
Sorry, just question.
Yes.
I just hope I've got him this time around.
You are, sir.
Yeah. So what's the definition of cytotoxic drug induced cardiotoxicity now? Is it a drop in 10% or a drop in 15% for a non-failure patient and 5% or 10% in a cardiac failure patient?
Are you talking about using GLS or ejection fraction, sir?
Yes, it's and or. So we can use either two. That's what we are saying. And the patient can be either symptomatic or asymptomatic, and still further classified into mild, moderate, severe, and very severe, based on if patient is symptomatic or asymptomatic. So if patient is symptomatic, for instance, now, and we have a drop in GLS less than 5, like Dr. Briggs said, qualifies for cardiotoxicity. Even if patient is asymptomatic and the GLS is between 40 and 49, is cardiotoxicity. However, if patient is asymptomatic, no symptoms of heart failure at all, we now have a drop in ejection fraction more than 10% and or a drop in GLS more than 15% and or elevation of cardiac biomarkers, that's NT-proBNP or troponins from the baseline. That's cardiotoxicity, even without symptoms.
Okay, thank you very much.
Yeah, thank you.
Okay, there are also Dr. Sorry, the doctor who just talked, please, I keep forgetting your name, Dr. Allison. And then there's also a part where ECG plays a role in cardiotoxicity. I don't know if you went through such, like when you notice a patient has prolonged QT, prolonged PR interval, STT wave changes, that could also help to detect to aside the GLS, aside the GLS and left ventricular ejection fraction. So once there's a change in any of these parameters, either using ECG, GLS, or echo, the patient is being or meets the criteria for chemotherapy-induced cardiotoxicity. So it depends on what you are using, either ECG, echo, or you're using GLS. So either of them can actually define the patient as having chemotherapy-induced cardiotoxicity. So thank you.
Thank you very much. Can we now move on to the next question, please? The correct answer is lisinopril. Thank you. Okay, so question 84. Which of the following statements concerning the cardiac catheterization evaluation of valve orifice area is true? Option A, valve area as calculated by the Golling formula is inversely proportional to the flow across the valve. I think that's false. It's supposed to be directly proportional. Option B, accompanying valvular regurgitation will result in a falsely high calculated valve area because active flow across the valve is less than the flow calculated from the systemic cardiac output. I think that should be reversed. Well, I'll come back to that. Option C, calculation of mitral valve area typically relies on substitution of a confirmatory pulmonary capillary wedge pressure for left. Yes, this sounding right because okay, this sounding right. Then option D, thank you, sir. Thank you so much, sir. Option D, valve area calculation is more strongly influenced by errors in the pressure gradient measurement than by errors in cardiac output measurement. Well, for option D, I think it should be the reverse. I think the cardiac output measurement should influence more than the pressure gradient measurement. However, I stand to be corrected. Please let's go to option A, B, and C again, sir. Thank you, sir, for sharing for us. Okay, for option C, calculation of mitral valve area typically relies on substitution of a confirmed pulmonary capillary wedge pressure for left atrial pressure. I think this is very correct. This is very correct, I think so. Option B, accompanying valvular regurgitation will result in a falsely high calculated valve area because actual flow across the valve is less than the flow calculated from the systemic. I think the flow from the systemic cardiac output might be higher, but I'm not so sure about that. For option A, it is directly proportional to the flow across the valve. It's not inverse, it is directly proportional from the Golling's formula. Maybe I will share the formula on the general platform, or if anybody can help us share it. Thank you so much. So I think it is between B and C, but I strongly will go for C as the correct answer. Thank you. Please, further clarifications, please. Dr. Ajayi. Chief Ajayi, sir. Or any other person that has clarification on this.
Will it be helpful for us to look at the answer here too? Because
yes,
this is looking very strange.
Yes, please let's look at the answer, please. I'll just give it. It's looking confusing with them. Okay, yes, this is the Golling's formula. Yeah. Okay, so answer to question 84 read thus. The pioneering work of Golling and Golling provided equations to calculate cardiac valve areas based on the based on the measured transvalvular pressure gradient and blood flow. The valve area is proportional to F over K times square root of change in pressure, in which F represents the flow across the valve. Change in pressure is the mean pressure gradient across the orifice, and K is an empiric constant for the valve in question. In the calculation of metal valve area, a confirmed pulmonary capillary wedge pressure is typically substituted for the left atrial pressure. There are assumptions and potential pitfalls in the determination of valve area by categorization techniques. Because here in the Bolin equation is assumed to be systemic, that's forward cardiac output. The presence of regurgitation across the valve in question results in a falsely low value for F in the Bolin equation, and therefore the calculated valve area may be underestimated. In such cases, the calculated valve area represents the lower limit of the true valve area. Accurate and simultaneous determinations of cardiac output and mean pressure gradient are essential in the determination of a stenotic orifice area. Both of these measurements are subject to error because it is the square root of the mean pressure gradient that is used in the Bolin's formula. Errors in measurement of the cardiac output have a proportionately greater influence on the calculated valve area. I should think this answers the option D, and also A, B, and C. I think it answers the options given above to the question. I don't know if we can go to the next question. Okay, so question 85. A 56-year-old man who underwent coronary artery bypass graft surgery 6 years ago has experienced exertional chest discomfort in recent months. He is not able to perform an exercise test because of chronic hip pain. He undergoes an adenosine positron emission tomography vasodilator stress test, images from which are shown in figure 1.21. What is the correct interpretation of this study? A, no perfusion defect. B, a partially reversible defect of the entire anterior wall. C, a severe predominantly reversible defect of the anterior wall. D, a fixed defect of the anterior wall without reversibility. E, fixed defect of the apex and lateral wall. Please, sir, can we go to the figure? All these perfusions, kind of stress testing. Right, see. Okay. So we've been seeing a lot of stress testing and perfusion scans since morning. So the thing about this one is that they use a pharmacologic agent because the patient cannot walk. So we should note that. So the first part, that's the essay, that's the short axis, apex to base. The first panel is a stress test, while the second one is a resting. And for the first part, of course, there are some areas of low perfusion. That's in this, yes, in the stress. Yes, I think those are areas of poor perfusion. Yes, sir. Yes, just those places. Yes. And in the resting part, you can see that it seems as if all those places are properly perfused. Then for the second panel, yes. HLA, there are areas of defect, poor perfusion during stress, yes. And at rest, there are still some areas, although it looks to be perfused, but there are some areas of poor of defects. So, for the third panel, this is septal to lateral, I think. During stress, there are areas of poor perfusion, and also at rest, there are areas of poor perfusion, but not as much as during stress. I think that will be my interpretation. I don't know whether I've interpreted that properly, but so please, sir, let's go back to the options. 85. See. Okay. So option A says no perfusion. Okay. What is the correct interpretation of this study? Option A says no perfusion defect. I think there are perfusion defects, just as we've seen. Option B says a partially reversible defect of the entire inferior wall. We noticed that even in all the images we looked at, there were still areas of defects and low perfusion in some of the images, especially the inferior part. So I don't think that it's partially reversible. I don't know. Option C, a severe predominantly reversible defect of the anterior wall. Well, I'm not sure of that. Option D, a fixed defect of the anterior wall without reversibility. That one is out of it. Option E, fixed defect of the apex and lateral wall. I think that one is also out of it. In all the images we look at, there were no particularly fixed defects. So I think the answer will be between B and C. But I don't know. Dr. Ajayi, you're an expert at this perfusion scan, this stress test. Can you help out? Thank you. Or any other person that can help out, please.
Yes, thank you very much. Sorry, my screen froze earlier, and my phone and I were speaking as usual.
Sorry about that, Chief.
Thank you so much. So I agree with you. A is false because no, A, the correct interpretation to say that there are no perfusion defects is false. B, a partially reversible defect of the entire inferior. C, a significantly reversible defect. I think C. I would go for C. Looking at those frames, a fixed defect of the anterior wall without reversibility, that is false. All showed some degree of reversibility. Fixed defects of the, no, that is also false. So I agree with you, it's between B and C, but I think there are lots of areas. Yeah, looking at this, if you look at the upper one, the stress images, there is a lot of the anterior area, the septal, the anterior, and the anterior area. There is a lot of perfusion deficits there. So I would go for, because inferior doesn't seem to be as badly affected as the septal and anterior areas. So I would go for option C. Perhaps we may, but even though I don't know whether you people observed, or maybe it's my glasses that is just deceiving me. It was almost as if there was some, okay, no. I was just looking at this last panel. Is the cavity, are they looking the same, or is the upper one slightly enlarged? Because for me, the upper one seems fractionally larger than the rest images. Yes, if you compare that to the one above it, to me, and even the next one towards the right, it also seems as if there is a slight enlargement of the upper one compared to the lower one. But maybe we should see what the book says, but I would opt for C.
Okay, thank you so much, Dr. Ajay. Any other additional comments that can help us here? Or should we just check the answer? Or what do we think?
Yeah, let's just check the answer. The answer is the final word on it. They are the ones with the knife and the yam. So
Okay, Dr. Sawa, sorry for stressing you. Let's go to the answer. Okay, so it really does. Exercise testing is the preferred stress modality to evaluate for coronary artery disease because it allows a correlation between exertional symptoms and objective findings of ischemia and provides substantial prognostic information. However, many patients are not capable of attaining a sufficient level of exercise because of physical limitation or poor conditioning and undergo pharmacologic stress testing instead. The most widely used agents for pharmacologic stress testing are 1. Coronary arteriolar vasodilators, regadenoson, adenosine, and dipyridamole. 2. Adrenergic agents such as dobutamine. During pharmacologic perfusion, positron emission tomographic scintigraphy of a normal individual, there is homogeneous uptake of the radio tracer throughout the myocardium in both the exercise and resting states. The images in the case of the patient demonstrate severe vasodilator-induced ischemia hypoperfusion of the anterior and anteroseptal wall. That is, there is a large region of hypoperfusion on the stress images that is predominantly reversible. It almost completely fills in on the resting images. A fixed defect is one that is present and unchanged on both exercise and rest images and corresponds to a region of prior myocardial infarction or scar. This patient subsequently underwent cardiac catheterization. A 90% stenosis at the anastomosis of the left internal mammary artery to the left anterior descending artery was found, and successful PCI was performed. Thank you so much. Thank you, Dr. Sawa. Question 85. No, sorry, 86. Thank you. A 40-year-old man presents to his physician with shortness of breath on exertion, peripheral edema, and arthritis of his hands. On examination, his vital signs are normal. His sclera are icteric and his skin has a bronzed hue. Lung examination demonstrates rales at the bases. The carotids are of normal upstroke. The cardiac impulse is displaced laterally and there is an audible S3. His abdomen is distended and evidence of hepatosplenomegaly and ascites. There is peripheral pitting edema. Laboratory studies reveal a serum glucose level of 225 mg per dl and a transferrin saturation of 70%. Which of the following statements about this condition is true? Excuse me. Okay. Option A, it is inherited as an autosomal dominant condition. Option B, cardiac involvement results in a mixed dilated and restrictive cardiomyopathy. Option C, ventricular hypertrophy with increased KRS voltages is the most common electrocardiographic findings. Option D, echocardiography often shows a thickened ventricle with a granular sparkling appearance. Okay, so the first thing here is to try and tease out what exactly they're talking about. And I think them giving us that bronzed appearance actually gives it off. So, hemochromatosis, that's what I think they're talking about here. And for hemochromatosis, if we remember very well, what the way I've always coded it is that it's AR, is on HFE3, chromosome 6. That's the way I've always coded it, but I don't, so that means it's an autosomal recessive and it's not autosomal dominant. And the gene is on HFE, I think that's HFE chromosome 6. If I recollect, it's been a while already, if I recollect very well. So I don't think the correct option A is A. Option B, cardiac involvement results in a mixed dilated and restrictive cardiomyopathy. I think that for option B, if I can recollect about hemochromatosis very well, it depends on the stage and the level of progression. So the stage and the affection of the heart will determine what is seen. But most times, a restrictive cardiomyopathy pattern can be seen. I'm not so sure about that mixed dilated. So I will move on to the other options to see what is likely correct. For option C, ventricular hypertrophy with increased KRS. No, they have low KRS voltages because there is deposition on the heart muscle, so the KRS is almost always low voltages. Option D, echocardiography often shows a thickened ventricle with a granular sparkling appearance. I think this is most often talked about in amyloidosis. So for this, I will be taking B as the most correct option here. I don't know whether there are further clarifications to this. Thank you. Please comment clarifications. Okay.
I think you're right.
All right.
Answer is B. All other options there are obvious, evidently false.
Okay. Question 87. Okay, question 87 then.
Please, in checking the answer, does it say whether there is usually even though it's mixed, did it say whether there's a preference for it to be more of dilated or for it to be more of restrictive?
Well, I did not check the answer. Unless if you all want to look at it together. I just stopped from the
class. I'll check it afterwards. Don't let me slow down the class. I just wanted to know whether there's a preference in case the question comes out with another form. Thank you.
Thank you, sir. Okay. Another stress test.
No, this was the last one. It appears your heart.
Sorry.
It appears you have
the last
skipped.
question.
Yes, sir.
Please, sorry. The last question I just checked now. They said hemochromatosis. It initially causes a diastolic dysfunction. That's a restrictive pattern. Then in later stages, it gives a dilated cardiomyopathy.
Okay, thank you.
So I don't know whether that will help.
Excellent. Thank you so much. That was why something was ringing in my head that I think there is so it depends on the stage. Earlier, restrictive, later, diastolic. Thank you so much.
And I also think that I can't remember, but I think it's also reversible if you pick it early and you start correction early. I don't know, but if somebody can check that up too. I think
Yes.
so, but
Okay, let me browse it.
Okay.
okay. Okay, so while they are checking, let me just move on to the next question. We have 9 minutes left. So question 87. A 56-year-old woman presents for routine evaluation. On examination, a systolic murmur is noted. Which of the following responses to maneuvers will be suggestive of mitral valve prolapse as the cause of this murmur? Now, what for this murmur, so? Biko, I need a code for this murmur. Okay, so let me read the options. Option A, mitral valve collapse. Okay, option A, with isometric hand grip, the murmur starts earlier in systole and becomes louder. B, with standing from a supine position, the murmur begins later in systole. C, carotid sinus massage increases the intensity of the murmur. D, Valsalva maneuver causes the murmur to arise earlier in systole. E, squatting from a standing position move the onset of the murmur earlier in systole. Okay, I think I will just throw this to the class so that I don't waste time trying to tease it out. I can remember that I think MVP has a systolic murmur, if I remember very well, but I sure need help here. Thank you. I know
Okay,
that
let me just say little.
yes.
Mitral valve prolapse is a cause of a late diastolic systolic murmur. Late is a cause of a late systolic murmur heard in the apex.
Okay.
And before you hear the murmur, you hear a mid-systolic click. So most times what is happening with hokum, that's what is happening with mitral valve prolapse. So Valsalva will increase mitral valve, Valsalva will increase preload, thereby increasing hokum murmur and mitral valve prolapse murmur. Do you understand? Because it's going to increase left ventricular, it's going to decrease, left ventricular volume. That's Valsalva.
Okay.
So
I
by
get that.
decreasing left ventricular volume, it's going to make the murmur louder for both of them. So now, if there's reduction in preload, which will make the murmur louder, so that reduction is likely to make the murmur start early. So you hear the click early. Does it make sense?
Yes. Thank you. Beautiful sense. Thank you so much. So that means looking at this option with what Dr. Alagbe has just explained, squatting from a standing position, that one will increase preload. So that one will not increase that one will not cause the murmur of MVP or hokum to come earlier. So that means option E is out. Option D, yes, which is what she just explained, is likely to be a correct answer here. Option C, carotid sinus massage increases the intensity of the murmur. I don't think so. I don't think so. With standing from a supine position, the murmur begins later in systole. Dr. Alagbe, will this be earlier in systole rather than later? Standing from a supine position. It will be earlier in systole with what she just explained. Then option
yes, it will
A.
be earlier in systole.
Yes, thank you. Option A, with isometric hand grip, the momo starts earlier in systole. This will be later in systole. Thank you so much. So I think the correct answer here is D, although I can't really explain that C. Thank you.
I don't know any relationship with carotid massage and mitral valve
Okay,
prolapse.
let me give it a shot. See.
Thank you.
We all agree that mitral valve prolapse momo is a late systolic momo. Okay, and if we look at the hemodynamic changes in the two chambers and with relation to the pressure changes and volume changes, okay, it actually, first thing that actually happens, okay, as at the time of beginning of, at the beginning of ventricular systole, okay, there is isovolumetric ventricular contraction. Okay, now at that point, there's this, at that level, the volume, the pressure between the at the early phase, the pressure between the ventricle, left ventricle, and the left atrium are almost equal until it continues to increase until it gets to a point where the pressure in the left ventricle exceeds the one in the left atrium. Now, at that point, the mitral valve closes. Pressure in the left ventricle continues to increase. So you can now see that this is actually a later event that occurs during systole. So by the time the pressure finally exceeds what is inside the left atrium, because of the prolapse mitral valves, it will bulge in back into the left atrium, and that gives us the click first before the momo now starts. So whatever it is that one, the hemodynamic changes now that will occur, that is going to result in decrease in contractility of the left ventricle, definitely will affect the pressure gradient in the left ventricle. I don't know if you, am I audible?
Yes, you are.
Okay. So anything that reduces our contractility, the strength of contraction in the left ventricle, will definitely affect the timing of those pressure changes, and by extension affects the timing of the bulging of that distance and the momos and the regurgitant momo that occurs in mitral valve prolapse. So if you do a carotid sinus massage, what are you doing with respect to sympathetic and parasympathetic? Because it's the carotid sinus there. I think by the time you do a carotid sinus massage, you are actually reducing parasympathetic stimulus now, isn't it?
Exactly. You're slowing the heart.
You're slowing the heart. You're
Yes.
slowing down the heart. So that means you're increasing parasympathetic and reducing sympathetic. So you are reducing contractility of the heart.
Yes.
Okay, so when you reduce contractility, you are reducing pressure gradient in the left ventricle.
Okay.
So pressure gradient has reduced. Do you now think if you do carotid sinus massage, it will increase the intensity of that momo with a reduction in pressure gradient? Definitely, it will reduce it.
No, definitely. Yes.
So that's the way I see this option C. I don't know if I'm making sense.
You made more than a lot of sense, sir. Thank you so much.
Thank you.
Yes, electronic hand is up. Dr. Onelum. I hope I pronounced your name well. Dr. Onelum Inneka, do you have a comment for us? Hello?
Hello?
Yes, Dr. Ayodeji, yes, please.
Yeah, I posted something on the group on that MVP from Manor of Cardiovascular Medicine. I think is well explained there.
Thank you so
I
much,
posted
sir.
on the group. Thank you.
Thank you.
Okay. Maybe the electronic add
Sorry,
up,
please, it's a mistake. Sorry.
we guess as much. Thank you. Well, it's 11:01, but with the permission of the class, I think we should reach, if we can reach 100, let's reach 90 so that we can go and sleep. Question 88 already, but it depends on us. We can say we should halt now, or we can reach 90 and then take a break. This was the consensus. Continue, stop.
Let's hit 90 now, I suggest.
Thank you for your suggestion. Is there a seconder, please? Okay, thank you for seconding. I can see people's mind that they want us to continue. So question 88. Which of the following statements regarding the effects of the potassium concentration on the ECG is true? A, the earliest electrocardiographic sign of hyperkalemia is a reduction in the P wave amplitude. B, deep symmetric T wave inversion are characteristic of early hyperkalemia. C, hyperkalemia produces digitalis in these tachyarrhythmias. D, prominent U waves are a characteristic feature of hyperkalemia. E, QRS complex widening is common in severe hyperkalemia. So looking at the option, I know that in hyperkalemia, there is QRS widening. Yes, prominent U waves, I think they are seen in hypo and not hyperkalemia. Hyperkalemia predisposes to digitalis induced tachyarrhythmias. Well, for that, I think it's more of hypokalemia than hyperkalemia, but it stands to be corrected. And sometimes it can be both, but I think it's more of hypokalemia. I think so. If you look at the mechanism of
Yes,
action of the
it's hypo.
is
It's hypo.
Okay, thank you.
Hypokalemia wasn't digoxin toxicity.
Okay, thank you. Then option B, deep symmetric T wave inversion are characteristic of early hyperkalemia. I don't think so. We always talk about all tainted T waves. I don't think that is T wave.
Yeah.
It's not inversion.
It's tau-tainted T wave, not inversion.
Yes. Then the earliest electrocardiographic sign of hyperkalemia is a reduction in the P wave amplitude. I don't think that's the earliest manifestation seen on ECG, but right now I can't recall the earliest thing seen as concerns the P waves, but I don't think it is the reduction in P wave amplitude. That it could also be tau. I don't know. So looking at this option, I'll choose option E as the most correct, but I still need an explanation for A. Thank you so much. Sorry, please, any contribution or comment?
I think the earliest electrographic sign of hyperkalemia is the emergence of tau-tainted T waves. If a patient has if we are suspecting hyperkalemia, of course, we can easily do an ECG even before the serum electrolyte and creatinine is out. And what we are looking for is we are looking for, tau-tainted T waves. Of course, as the severity progresses, then we have widening of QRS complexes, shortening of the QT interval, flattening of the P waves. But I think the earliest is the tau-tainted T waves, but we should confirm. But that's what comes to mind. So yes, I agree. I think E is the correct.
Okay, thank you so much. Okay, the answer is E. Answer is E for 88. Question 89, please. 89. Which of the following conditions can result in significant electrocardiographic Q waves in the absence of infarction? Significant. What defines significance here now? Right bundle branch block. Option A, RBB. Option B, small left ventricular size. Option C, acidosis. Option D, WPW syndrome can result in significant in the absence of infarction. Okay, I think the catch here is the presence of Q wave in the absence of infarction. So for option A, let me keep that one somewhere. Option B, small left ventricular size. I'm not sure that they have significant Q wave. I think they don't have acidosis. I'm not accepting that's an acidosis unless there's some form of infarction or ischemia ongoing. Maybe we might see such changes maybe we can see some changes in patients that are acidotic, possibly. WPW syndrome, yes, they have Q waves in the absence of infarction, but I don't know whether it's significant. RBB, well, that one, I'm not so sure. So please, I need help here. 89. Hello, Sazamas. Please, am I audible? Dr. Sawa, help us out.
Wow. I really don't have an idea.
I'm also not sure. For that person, I'm thinking of LBD, but I'm not sure.
No, I can give it a try.
Please, thank you.
Yeah, for the question is, sorry, what question? We're on 88, 89, right?
Yes,
sorry,
please.
I've been distracted. Okay. Which of the following conditions can result in significant ECG Q waves? Okay, in the absence of an infarction. Okay. So conditions. Okay, A says right bundle branch block. So that will be false. It will rather be an LBB. It's in LBB that we have absence of the septal activation, that we have Q waves in the anterior chest slits now. So I think if they had put RBB there, it would be right. Instead, LBB rather, it would have been right instead of RBB. Then B says small size left ventricle. Okay. Would have rather preferred a large size ventricle, like in the case of maybe hypertrophies that gives pseudo infarcts, like the amyloidosis or other infiltrating diseases, or probably an HCM that will give this dagger or deep Q waves in the inferior lateral leads, so to speak. So small size left ventricle will be wrong. It will have been large size ventricle. That's my thought on that. Then C says acidosis. Okay. Well, I know acidosis. When do we have acidosis? We can have, it's even alkalosis that we have in pulmonary embolism. But acidosis, I know acidosis will have, goes with, okay, can go with hyperkalemia. So acidosis going with hyperkalemia, I don't think we have Q waves there. Which other things can we have with acidosis? I'm not sure now, but that's the only thing I can think of now. Then D, Wolff-Parkinson-White syndrome. Either types does not really give us this thing, because is an accessory pathway, and definitely we have activation of the septal, so it's not likely we have absent R wave. So I think D might be the answer here. Between C and D, but I think D might be the answer here.
Okay. Thank you. Thank you.
Please, let's check.
Hello.
Hello.
Hello. Hello.
Hello, we can hear you.
Well done. Good evening.
Good evening, sir.
The WPW syndrome is known to give an inferior Q wave, significant inferior Q waves. In addition to what the last speaker just said, I think she gave elaborate conditions that are associated with Q waves. But in this option, WPW will give you a Q wave.
Thank you very
Non-infarction.
much.
Yes.
Okay. And the answer is D, actually.
Yes, the answer is B. Okay.
Thank you.
You are telling us the answer already, Abi?
Yes, as in you explained the answer, reason why it is the answer. So I went to check. So it is D.
All right.
Yes, thank you, sir.
So meaning
Question.
is significant here. Is that the interpretation? That means the Q wave is significant. Sorry, I didn't get that.
Yes, it gives the significant Q wave. It gives a significant Q wave.
Okay, unlike
not,
others, all right.
Yes, but it's not it's not due to infarction. Usually it's due to inferior posterior activation in the LEDs.
Yeah, okay. Thank you.
Okay. So I just browsed it now to just to say more to what he said. They said inferior lead pseudo infarct Q waves are a common finding in WPW.
Okay, but when they say significant, what describes that? Is there a particular percentage, out the depth of the Q wave, or what? Or the number of leads affectation?
I think left to me, I think significant Q wave is still maybe the same thing, that the same criteria we use for pathological Q wave.
Okay.
That's when it's like one small box deep and is it 0.04 milliseconds, right? That's what I feel. I feel significant and pathological. I feel it.
Yes,
Yes.
that's
0.04 milliseconds. That is one small small box, or 25% of the QRS complex.
Okay.
Okay. Thank you so much. So the last question for today, question 90. Which of the following statements regarding the interpretation of exercise ECG is true? Option A, the presence of RBB does not alter the sensitivity of exercise electrocardiography for the diagnosis of myocardial ischemia. Okay. Option B, ST segment depressions in the inferior leads during exercise testing are specific for significant right coronary artery disease. Option D, the location of ST segment elevation during exercise testing predicts the anatomic site of clinically advanced coronary stenosis. Option B, digoxin therapy is not associated with false positive findings on exercise electrocardiography if the baseline ST segments are normal. So looking at this option, I will start with option D. Actually, when you say digoxin therapy, they can actually accentuate or give false positive findings. So I think option D should be that it does when they're on that therapy. Option C, the location of ST segment elevations during exercise testing predicts the anatomic site of clinically advanced coronary stenosis. I think this is correct. That's what I think. Option B ST segment depression in the inferior list during the exercise test specific for significant right coronary artery disease. I don't think this is correct. Option A, the presence of RBB does not alter the sensitivity of exercise. It should surely alter the sensitivity. So yeah, I think the correct option is likely C, looking at the other options. Thank you. Please further comments and clarifications.
Is how many options do we have there?
Oh, sorry, can we see option E, please?
There's no E.
Oh, thank you, sir.
Okay, I think you're right, but hello, the option A, if you look at in exercise stress tests, there are baseline conditions where interpretation of exercise stress test becomes problematic. It does not include right bundle branch block. It is left bundle branch block. So anytime you see a baseline left bundle branch block, automatically there is going to be a problem with repolarization. And during stress tests, it's the repolarization it's the repolarization pattern that guides our interpretation. So right bundle branch block does not actually alter okay. No, yeah, this is not true. It alters sensitivity. ST segment depression, yes, ST segment depression because of
please,
atrial repolarization.
Please, sir, I'm trying to understand what you said about the A.
Sorry, I got it mixed up. Yes, left bundle branch block and right bundle branch block. Left bundle branch block, yes, it alters more than right bundle branch block. So A is true. A is not true. Sorry.
That's what I thought.
Yes, A is not true. Then ST segment depression in inferior leads, yes, it's advised that caution should be should exercise quite significant amount of caution in interpreting ST segment depression, particularly in inferior leads, because of the atrial repolarization can also affect it. So it might not necessarily be as a result of exercise-induced ischemia. And the option C, when there is ST segment elevation as opposed to ST segment depression. ST segment depression cannot predict, does not correlate with vascular territory, but ST segment elevation does correlate with vascular territory significantly. And digoxin therapy is associated with false positive findings because it has this reverse tick sign normally, even without exercise. So if I use have patients on digoxin and beginning to have that downsloping ST segment depression, it's
even without exercise.
Yes, even without exercise, you can see downsloping. So by the time you do exercise and a patient is in digoxin and you're seeing downsloping, you should exercise some caution in making interpretation as being a positive test. So our answer is C.
Thank you so much, sir. Thank you so much, everyone, for allowing all of us to work together to drive today's session. I know that our target was 40 as at yesterday, but people that were supposed to discuss were unable to. And I'm happy that we could do 20. And this is because of every one of us. It's not because of me, because I was not also able to go through this before the class. And I'm happy that we've all learned so much. So I hand over to Dr. Uzoke and our consultants and trainers, Professor Oladimeji, Dr. Kweki, and Chief Okopi, if they're here. So Dr. Uzoke, thank you. Dr. Uzoke, are you online?
I don't think so. So this is a good stride tonight. I think I need to encourage us to keep all the spirit. We're moving very fast, so let's continue to move at the pace that we're going right now. I would suggest that over the weekend, if we can go through the question, it will become faster from on Monday. And then I also want to suggest that everybody that are presenting on Monday, you can drop a message with them so that they can remember that they need to prepare and be available for the presentation. So that'll be all for me tonight. Thank you. Good night.
Thank you so much,
Thanks very
Chief.
much.
Yeah.
Thank you so much, Chief. Thank you, everyone, for making it an interesting class today. And we pray that we all have success at the end of everything. Dr. Ozoke, is it like you're back?
Angie, thank you very much. I keep coming and going out, coming and going out.
Okay.
Thank you very much for standing in all true and true. Thank you, Dr. Ajayi, Stevens, Francis, everybody. Molade. Thank you, everybody.
Thank you, everyone. And good night.
Yes. Good night, all. Bye-bye.
Thank you. Good night. Thank you, everyone.
So we meet again on Monday. Thank you.
All right. Have a nice weekend, everyone. Good night.
Yeah, bye.